Hello, everyone. My name is Dr. Lang. I would like to welcome everyone and thank everyone for getting to our lecture in a series. And without further ado, we're going to ask Tamar to introduce today's lecture, please.
Yeah, thank you, Peter. We are going to talk about exposure therapy and treatment, and more so today about theory and basic information about exposure treatment. What's the idea and the theory behind it, and what different versions of exposure treatment we have. Because there's, I would say there's not the one, because I think the most broadly known is the prolonged exposure developed by Edna Foa, and I think in America is the most popular version, but it's not the only one. So I will try to talk about the exposure treatments and present the theory behind it. And we will have this like part one, and we'll have part two in 2 weeks time, maybe, where I will go into detail how you do it, what you do, and maybe to show demonstration of doing exposure treatment. Okay. As I'm not a native speaker, please excuse me for any mistakes I will make or I have in my presentation. Okay. Yeah. So let's get into it. So as PTSD is conceptualized as primarily an anxiety disorder, or was, I would say it was conceptualized as primarily anxiety disorder. And if we talk about like normal PTSD, not meaning the complex PTSD, is still mostly the case. That is the most prominent emotion, and the one that makes most difficulties for clients is anxiety in the first place. Even though we have to say it's not the only emotion, there are many other emotions involved in PTSD. We have helplessness, we have irritation, we have, depending on what happened, disgust. So it's not only about anxiety, but anxiety is, as I said, mostly the driving emotion that we usually encounter first when we start working on the trauma symptomatology. So reducing the anxiety is mostly the #1 target. PTSD treatments in general should also reduce negative emotions such as shame, guilt, and depression as well. So I want to, when we will dive into exposure treatment and how it works, I want you to always keep in mind it's not only about treating anxiety, but the exposure treatment as it is conceptualized now comes from conceptualizing PTSD as an anxiety disorder. And this is the habituation was one of the first driving ideas behind it. Even though there are other emotions and you have to target them differently. There are emotions, we will talk about them later, that do not habituate, you cannot do exposure and expect those emotions to disappear. So it's more complex than that, but if we focus on exposure, we have to talk about anxiety. Yeah, that's what I said. And exposure therapy is known also from other anxiety disorders. And we want, through when I talk about exposure therapy regarding post-traumatic stress disorder, I always mean imaginal, in this workshop, I mean imaginal exposure. So at first we are not talking about in vivo exposures, it's more in sensory exposures where clients have to go through the what happened through a trauma and confront themselves with the situation, with the thoughts and emotions that were present at that time ban. So it's about confronting, exposing themselves to the traumatic situation in the imagination. So it's an imaginal exposure. What we want or what we expect from the imaginal exposure is that through confronting the clients, confronting themselves with the situation, with the emotions that were present at that time, it will help them to process the whole experience and help them process the emotions, their thoughts, and the brain will be able to sort what happened then and be better able to leave the experiences in the past and not have not relieve those emotions and memories in the present day, and not have this feeling of as if it happens now again, like in the intrusions or in the flashbacks. So if you go through the memory, if you go through those emotions, the brain kind of does it automatically. Sometimes we need help. Clients need help from therapists. But if you do not dissociate during the process, your brain more or less automatically will sort through those emotions. And clients experience reduction of distress and experience that the emotions get less distressing and the memories fade away. Yeah. So the main goal is habituation of anxiety. That is the first target, usually reduction of distress, and then parallel to that, integration of corrective information in the self-concept and in the biography. That's what we want. Exposure is one way of treating PTSD or doing imaginal exposure. On the other hand, we have cognitive restructuring methods. So targeting not only the memories and emotions, but also the thoughts and beliefs that clients have developed after the trauma. These are catastrophic and unrealistic interpretations of trauma that are usually targeted for the future. So the clients think bad things will happen to them, they will never feel better again. Clients think the world is dangerous and they are have nowhere security. Anytime bad things can happen to them. So those kinds of thoughts are very prominent and hinder clients to live a life worth living. So it's not only about habituation, but also about changing and restructuring those thoughts, and it needs to be incorporated into the treatment. Yeah. Sometimes some clients, if we're talking about very classic PTSD and maybe also about easier cases, lighter cases, clients will do those processes often automatically during the exposure. So when they go through a traumatic event, relive the situation, the brain starts to sort through the memories and the thoughts and emotions, and those cognitive changes happen automatically. But as soon as cases get a bit more complicated, when other emotions are involved other than anxiety, then usually a focused cognitive intervention is necessary. So what is imaginal exposure? Clients, when doing imaginal exposure, clients get asked to recount the identified index trauma. We call index trauma when clients have only one trauma, that is the index trauma. So the trauma that distresses the clients the most in the current situation or nowadays. If we have a chronic traumatization or multiple traumatization, index trauma is the one that is currently the most distressing and the one we are targeting in therapy now. So it has to be the most distressing one. That is crucial. Yeah, most distress. In the imaginal exposure, clients get guided through approximately 30 to 45 minutes of imaginal exposure to that event, to that index event. In the prolonged exposure version of exposure, so to say, in the PE conceptualized by Edna Foa, she says they usually start with 45 minutes of exposure, and if the trauma is shorter than 45 minutes, or they don't take the whole 45 minutes in the first run, they will start again until 45 minutes are over. So they would also do multiple exposures in one session. That is not the case with trauma-focused CBT version of cognitive of prolonged exposure. But I will talk about that later. So clients are asked to close their eyes, imagine the traumatic event as vividly as possible in front of their inner eye, and tell what they are seeing in the present tense. So it's like, tell me what you are seeing in front of your eye. And clients start to talk. They have the eyes are closed, and they try to focus on that experience as good as possible. Here again, we have two versions how you can what the role of therapist is during the exposure. Basically, or typically, therapist helps the client to identify and describe thoughts and emotions during the traumatizing event, and guides the client through the exposure or through the recounting or telling. Asks also how high is the SAT now, for example, and helps the client to talk. At the same time, in the classical PE or prolonged exposure, therapist is not allowed to talk a lot, as it is considered disturbing, so you want the client to be reliving in the process as much as possible. So through me talking and asking things, I am distracting the client from his or her experiences. So therapists are quite passive and do not ask many questions. They are not allowed to ask any kind of cognitive restructuring questions. You are just only staying with the trauma. So maybe the typical questions are, okay, go on telling, or what happened next? What did he say? Whatever, but not too often. That's really important for prolonged exposure in the classical way as it was conceptualized. Yeah. After recounting, so after you have gone, one thing is you start at the point where the situation gets distressing for the clients, and you go through the whole index situation until the client feels safe again, or you would say relatively safe. It's not until the client went home, but maybe until to the point where the situation was over for that moment. The client was rescued, or the client knew the perpetrator goes away. So this is the beginning and the end of the index situation. After recounting, therapist and client discuss client's reactions and thoughts during the exposure. So you have this exposure time, the imaginal exposure, and after the exposure, you discuss what the client experienced during the exposure, what are the thoughts and the prominent emotions that came up during the exposure. You have like cognitive restructuring, the cognitive part after the exposure is over. And this is a very important part, as you process what you have relieved in the exposure after the exposure, and sort those things, sort your thoughts and emotions and experiences, and it helps clients to understand the situation better. So it's usually this cognitive restructuring or cognitive talk about after the exposure is like a must part of the exposure. It's really important to have enough time to talk about what clients experienced or had experienced. Also, it helps clients calm down. It's also got a cool down phase, sort themselves again, so they can leave your office securely. The homework after the exposure process starts, the exposure sessions, of the part of the session that is imaginal exposure gets recorded, and clients are supposed to listen to that recording every day until the next session. During the listening of the recording, they are supposed to try to focus on the exposure as vividly as possible, to again relieve the emotions and thoughts that were there at the time. So this listening to the exposure helps them work on the trauma and on the emotions between sessions. So you have you see the effects much quicker. Yeah, that's a classical idea of imaginal exposure and exposure treatment. So what is the difference between prolonged exposure in the way I presented now to combining prolonged exposure with cognitive therapy, like that's what would be trauma-focused cognitive behavior therapy. So PE focuses mainly on habituation. So that is, PE conceptualizes PTSD as primarily anxiety disorder, and as other anxiety, Edna Foa worked, her main research domain are OCD and anxiety disorders. So if you conceptualize PTSD as an anxiety disorder, and she applied the same methods that are used in OCD treatment or anxiety treatment for PTSD treatment. And it is true for some part. As I said, if you have like anxiety is a primary emotion, it does work, but it gets to its limits when it is more than that. I would say that PTSD is not a classical anxiety disorder. It's a stress-related disorder. You do not do PTSD justice if you only conceptualize it as an anxiety disorder. And the same rules that apply for treating anxiety disorders do not apply for treating PTSD, also in the exposure therapy. For example, if you were doing exposure for agoraphobia, and you would be doing exposure outside in a shopping mall, you would not want the client to be distracted, because it does not work in that way. So they really have to stay in the emotion, in the situation, and they are not allowed to distract themselves in any way. So that's where a therapist would be very passive. I would not be talking too much to a client in a shopping mall doing exposure with me. I would not try to intervene cognitively at all. I would not want the client to make pause or leave the situation and go into the situation again. That is not how exposure usually works. Those rules do not apply for PTSD treatment, even if we are talking about anxiety as a primary emotion, because you can make pause during the imaginal exposure, for example. It's no problem at all. It will not change the effectivity of the exposure. You are allowed to ask questions and be active, and it is not avoidance of the emotion. Even more, if the client has a complex PTSD, you usually need to ask lots of questions, and you need to make pause. Otherwise, the exposure will not help, because clients get very overwhelmed and dissociate. So it's completely, I would say, it is completely different from treating classic anxiety disorders. You cannot really compare. Saying that, of course, if you do exposure and you expose to the anxiety and do it as you do with the classic anxiety disorders, and the clients have a normal PTSD with the anxiety as a primary emotion, it will work, no doubt, because exposure treatments work. But as I say, usually it's more than that, and that's where PE gets into its limits. So the first problem what we have is that some emotions do not habituate. Anxiety does, but there are many emotions that do not habituate. For example, helplessness does not habituate at all. You cannot expose to helplessness and hope that it will go away if you stay long enough in the helpless state. Or guilt does not habituate. If you cannot feel guilty long enough, it will not go away. It will only get worse. I would say the same with shame. It does not habituate as well. So there are lots of emotions that do not, anger, I would also say, is not typical emotion that habituates in the way anxiety does. The other emotion that habituates is disgust, and it does habituate. It's quite hard, or it takes much longer than anxiety. So with habituation, you cannot target all the emotions that are usually relevant for PTSD, especially the helplessness that is usually part of the symptomatology or the distress. That's one very important thing. That's where cognitive elements come into play and get very important. And the habituation as the biggest goal loses its importance. So you have to combine different things. You have to help clients change their emotions, primary emotions, and it does not happen if you only do not ask anything, just leave the clients in their emotions. So there, where we need the cognitive part in the exposure as well. So the trauma-focused CBT does exposure in a different way than PE does. So in the trauma-focused CBT, they focus more the hotspot situations of the index situation. So hotspots are the worst parts of the index trauma. So if index trauma is the most distressing traumatic experience, hotspots are the most distressing moments within the index situation. So clients, and you go those hotspots in a very with magnifying glass. So you really slowly, really second by second, to recount everything that happened at that moment. And the main aim of you tell the whole story in the beginning, and as the time goes by, after 2-3 exposure sessions, you try to focus more and more on the hotspot situations and get the change of emotions there, because they are the most distressing ones for the part of the index situation. You do not go the trauma multiple times in one session, only once. And therapist is very active and actively supports the client to identify and describe emotions, thoughts, and reactions, also bodily reactions, or physiological reactions that were present at that time. Because the problem is, the clients, if you do not help them with the questions or with your questions, they only tell things they want to tell, and it is really hard if you have PTSD to go into those kinds of details. The avoidance is real, and if we're talking about if your car crash is maybe easier to tell, but if we're talking about or thinking about sexual abuse or rape, there are parts that will be very shameful, and clients have difficulties just telling those things. So they usually skip them, or skip the thoughts and skip the emotions. They only tell the story. And as we conceptualize PTSD nowadays as stress-related disorder, and that role amygdala plays in PTSD, is that we have this trauma network that appears in our head. So clients have saved the whole information, the details of the trauma in their head, and this is what is causing distress, because they know too many details, and those details are connected with the emotions they experienced or they had at that time. So if they feel the pain and they have the thoughts, I will die, they hear the crash, and it feels as if it was happening now. So, and they have the smell of the car and they see the things. So what you want to do is to help the clients verbalize all those details that are saved in their head. So not only telling what happened, but also helping them to talk about the details. So what are you hearing? What is going through your head in that moment? So how does it make you feel? What are you experiencing in your body when you feel like that? So on and so on, because all this information is there. So what we want is to the clients to realize that they are there. That's the first thing, and verbalize them so the brain gets hold of them and can sort them better. We want to kind of get them out of the amygdala treasure and make accessible for our prefrontal cortex. And that's what happens when you verbalize things and name them. And often the details are the distressing ones. For example, sometimes I need to ask clients, or I think it's important to ask, so what are you seeing in front of your eye? They would not tell me that because they are talking about something what is happening. Maybe they are getting raped and they are telling, yeah, and then I feel his penis and so on. And I say, what are you seeing in front of your eyes? And then the client says, oh, I see the face of the perpetrator. And when I say that, or when I ask that, I notice how the distress rises, because they now have to tell me what they are seeing, and the face of the perpetrator may be really distressing. And they would maybe avoid or not think about telling me that. But it causes a lot of distress, and they have maybe the face of the perpetrator is a trigger in lots of situations outside and so on. So it's very important to think about what was there, or what is the client seeing, and like I go with in my mind with the client step by step, trying to get the whole image, and with like you get the whole image with the emotions, thoughts, and bodily reactions of the clients. That is how exposure works. Yeah. And cognitive interventions are allowed during imaginal exposure. Of course, you do not want to lead like Socratic dialogue or discuss things during exposure. It is not allowed because it would be too much of a distraction. But like very specifically asked questions are really helpful. For example, if clients feel helpless and you ask also what would you, they are anxious, and you ask what would you like to do, and clients say I would want to run away or fight back, and I ask, can you do that? Clients say, no, I can't. Why? Because he's holding me and I feel his hands. And where I can go, it's dark and I'm alone here. And the next question that comes is, how does it make you feel when you realize he's holding you and you can't escape no matter what you do? You can't really fight, you can't really run, you are stuck. How does it make you feel? And it's not only anxiety. Of course, I'm afraid what he will do, but it's also this big helplessness that arises, knowing I just can't do anything. To realize that, first of all, it needs my questions to lead clients to the helplessness that they experienced, and re-experiencing the helplessness of that time helps counteract the guilt clients are feeling. and change the guilt on emotional level. That is really important. And at the same time, I know, okay, client is feeling helpless. So what can I do now? That's when habituation does not work, because if I leave them in the helplessness, it will not change. They will still feel helpless. So like there are cognitive interventions that are really helpful to ask. First, you activate the emotion, that is really important. And then you ask, okay, at that point you were helpless. What do you know now? What is different now in your life? Yeah? So you introduce a change. So then you were helpless. You can't change that. It's about not feeling helpless nowadays in your present life. So I want the client to realize when I was helpless, but nowadays I'm not. And if they say it's one thing, of course they know it's over. They know they are in my office, but it's not about this cognitive knowing. It's more about feeling it and having that feeling, I am not helpless now. And this feeling can only establish itself if you try to change the emotions when they are activated. We talk about, or we call it the hot and cold emotions. So in the exposure, when emotions are activated, they are like hot. And if you have hot iron, you can change it better. That's the same applies for emotions. So when they are activated and hot, and you ask, what do you know now? It sinks in differently than if you talk about that in a cognitive restructuring right after it's all over. So if I ask them, what do you know now? And they say, I'm not helpless anymore. I can stand for myself. The situation is over. It does not happen to me again. That's what I want to hear. And leave it to that. Yeah, it doesn't happen to you again. It's over. You are not helpless now. Perfect. And then we move on. So one thing you have is you have that thought like integrated into in the hot emotion phase. And another thing is that you're listening to the recording multiple times during the week. So they listen to that again and again and again. And I have had clients who came in the next session and said, they did not realize it in that moment what I had asked, and then came and said, you asked what is different now. And then I realized that that's the same question I ask about fear to die, when they say I'm gonna die. That's also I'm gonna die. I need to change. It's not only habituation here as well. It's really helpful to say, what do you know now? And they tell me, I did not die. I survived. And then the client came and said, you asked what I know now, and then I realized I did not die. I thought I would, but I am alive. I did not die. And it was really funny because she of course she did not die. She was thinking in my office, but the feeling of that was not there. And that's why the PTSD was so active, because this fear of dying and it was like stuck at that point. And when she was relieving the intrusions, this fear of dying got activated every time. And through the exposure, that changed. And there was no fear of dying anymore, because she knew on the emotional level that was not the case. So her distress levels went down rapidly after that. So cognitive interventions can be really helpful. But keep in mind, it's only one sentence or one question. You are not discussing anything. If clients say something what I don't want to hear, for example, that you have plenty of clients who will say, when you ask, what do you know now regarding helplessness, they will say, I don't know. Nothing has changed. Okay, then I will say, okay, now I do not comment that. Maybe I will say, you have survived, but we will move on. You do not discuss things during exposure. That's what you do after the exposure, and try to incorporate the effects of cognitive exposure next time in the next exposure next week. So that's important. Yeah. And these are the biggest differences between PE and TF-CBT. So PE does not allow cognitive interventions. TF-CBT does it, and I think it's really helpful. Yeah, both is okay, I would say. We have data. But I would say when we are talking about complex PTSD and sexual abuse, I would opt for TF-CBT version of doing exposure rather than PE, as complex PTSD is more complex than only anxiety, as we know. So, what do you need to do exposure with the clients? So we have like a ready for exposure checklist. So just to go through some things that you need to check whether the client is stable enough to go through the exposure. Clients need to have skills to regulate their emotions and be using them on a daily basis. Clients have to have talked about their fears regarding exposure and what they are going to go through. Clients have to have changed their avoidance in escape strategies and have thought about them and start changing them at least. For example, avoidance strategies are not that important, but escape strategies have to be under control. You need to organize support for clients if they are a bit more complex than like really car crash situation. So if they have partners or and to think of friends or what kind of support they need, what is with work leave, can they go on working or do they need work leave for some time? So like organizational things you need to also keep in mind and to go through before you start into the exposure, because you do not want any problems during the exposure. Client has to agree to do the exposure explicitly and has to understand why it is helping and how it is helpful. Yeah, this would be the main things, I would say. So before you start in the exposure, you go the checklist with the client, together with the clients, and check if everything is okay. Clients have to have emergency skills kit that's from the DBT, if they need it. Have to have the information how things work. That's how it's said. And if you are working with a supervision group, I would advise you to talk with your consultation group about the treatment and check if client is okay and the things are okay if you're okay to start. Here I'm of course thinking about the more complex clients, not the like easy ones, because if you have like normal PTSD client with no other comorbid diagnosis, maybe you do not need a lot of work. You can just start. But if the clients are a bit more complex or complex PTSD clients, it is helpful to do a good preparation work. Yeah, clients need to, again, talking about complex PTSD clients, we require no suicide attempts or self-harm in the last 4 weeks, no crisis, here S is missing, no crisis generating behavior in the last 4 weeks, no cannabis, alcohol, drugs, and drug abuse in the last 4 weeks. The social situation needs to be stable, so low risk of re-victimization, preferably no pregnancy, no ongoing crisis in the near personal environment. And we I'm
writing fast, I can't talk.
We tell the clients not to take any serious decisions during the exposure phase, just to, if there anything that comes up, just to wait and take decisions later after the exposure is finished. Yeah, emergency skills kits. Yeah, what they need to also to do is distance themselves from the guilt cognitions. That's also something that needs to be like done. Guilt work, we will talk about guilt in the later sessions.
Rania, don't come over here and mess with the garbage. I don't want to do that.
And the clients need to know
Get
that
it.
they can say stop at any time during exposure. It's very important to tell clients that I am in exposure. I will be telling you, so I will be asking questions. I will guide you through the memory, and it's my job to ask you questions and help you through the story. At the same time, I don't know what you are reliving, and even if I am very focused on you, I do not see everything. So I need to be able to rely on you, that you tell me when it's too much and we can pause. So it's your job to tell me stop if you get overwhelmed and if you want a quick break. It's okay, we will do a break and we'll go into it again after we have, after it's okay for you. So breaks are allowed, it's okay. What is not okay, and I don't tell the clients, I'm just telling you, what I don't do is to break up the exposure. I may make a pause, but I do not stop the exposure. I always make sure to get to the end of the story before we end. No matter how, but it's important to go to the end point where the clients were feeling secure, not to get the client feeling, give the client feeling they have failed or did not manage to go through it. So it is the notion of I got through it no matter how is more important than telling the client or giving the client the feeling, okay, I was able to stop when I want it, because that's not what the exposure therapy or the trauma therapy is about. Yeah, that's it. I would say, yeah, I would say we stop here, because I think we have a part 2 coming of the exposure. So I would say that would be the basic things you need to know about exposure. And as we also want to have time for questions, I would leave it to that for today, I think. Peter?
Yeah, thank you, Tamara. And please ask questions. Now is a good time to do it. It's a Q&A session. If you have anything about the first part, please go ahead. Does anyone? Tamara, I think you did a good job.
If you don't have any questions, yeah, and we will, yeah.
Hello?
Yeah, hey, please go ahead.
Okay. Could we use another word instead of clients saying stop? Because I think that might signal some of my clients that, okay, we're really stopping the exposure and the processing and everything. Could they just say pause or wait a minute? Or, you know, I'm just thinking stop could be a little too definitive with those clients of mine that when they're in any kind of an imaginal state are in a very young developmental concrete thinking place.
So it's very important when you go through the checklist. I really go through the checklist with the clients to explain what you mean. It's not about stop. It's more about it's that you want to explain that they are allowed to ask for pause, and it's the way you want them or that feels right. They usually say, "Can we make a pause?" It's not about saying stop. It's just about the idea that they can make a pause.
Thank you.
Yeah, Mr. Chalula.
So, Doctor, the question, could you say more about the four-week period of abstinence from substances? That's with my population, that's
Not
Very
possible.
unlikely, very, very unlikely. I have referrals from the court because of substance use. I have adolescents who believe that marijuana is the be-all and end-all. That's the way they deal with symptom avoidance. So how might you approach that? What would you advise me?
That's a really good question. And I would say we are not talking only about exposure. So I was not talking about the stabilization phase that has to be done in the first place with those kinds of clients before you start into the exposure. So one thing is that you need specific like building up phase, motivational phase, psychoeducational phase, where you tell the clients, we will do exposure, but I need this, and that from you to be able to do exposure with you, if they are motivated to do that, to do the exposure. And like you work toward the exposure, trying to get hold of those problematic behaviors. That's the same with borderline clients with parasocial behaviors and cutting themselves, drinking alcohol and using drugs. So it's the same thing. So you try to teach them new skills instead of using drugs and alcohol and cutting themselves. So this is important, really. And that's why we need, like, the 4-week period will show me that they are committed enough to do the exposure. They have enough skills that they can use instead. That's the idea, and that's how we do that. And then you have, I don't know whether your clients are from that, like, you really dependence, drug or alcohol dependence, where you say it's impossible to get them clean because maybe the abuse or dependence is really directly connected to trauma. There are clients who cannot get clean, and then there are different ways to incorporate that into the exposure. So you can do exposure with substance consumption, but yeah, they're different. So you need to focus that differently. I think the manual, they have COPE. It's called COPE. It's combining substance use and prolonged exposure treatment. Yeah. I hope I answered your question. Yeah.
Thank you, Tamara. Does
Thank you.
anyone else want to ask something?
Then
we're probably going to leave it until next time, yeah?
I would say let's leave it to that, and we will go to the to demonstration and yeah, like really hands-on how to do exposure in the next session.
Brilliant. Guys, I also wanted to tell that the video will be available. I'll be sending links if anyone wants to watch it later. And we will notify everyone who wants to attend next time we're going to air the second part. Thanks everyone for attending, and huge thank you to Tamara for presenting today.
Thank you, everyone.
Thank you.
Have a nice day.
Bye-bye.
Bye.